everyone, and welcome. For this week, we are going to cover schizophrenia spectrum disorders. I had this request to teach this lesson by a lot of students because I think it's something that's often romanticized and it's used as a topic a lot in horror movies. And while some of the symptoms can seem kind of scary, for lack of better words, it's not a totally hopeless, kind of debilitating thing if someone does get diagnosed with schizophrenia. So we're going to talk a little bit about the symptoms, how this disorder could possibly manifest itself in someone, different variations, so the spectrum disorders, so other disorders that share symptoms with schizophrenia, as well as just looking at the different effects it can have on the brain and body. So what I've included here, I hope it popped up for you, is a link to an artist called Brian Charnley. Now, unfortunately, Charnley committed suicide in 1991, but he's well known for being an artist who did a lot of self-portraits, kind of demonstrating, I guess that's the word I'm going to use, kind of exhibiting the different ways he would see himself through his schizophrenia. So he did a whole portrait series on it, and so when you click the link in your PowerPoint, you're able to go and look at the different portraits that he created, and I think it's just a really interesting case study in the life of someone who has schizophrenia and how it can manifest itself in different symptoms, different ways in terms of perceptions. And I just clicked the link again. I'm sorry. Let me proceed. I don't know why it's not letting me go to the next link without. There we go. Alright, so for this section, we're going to describe the signs and symptoms of schizophrenia and related psychotic disorders, describe the potential risk factors for the development of schizophrenia, and describe the treatments that work for some of the symptoms of schizophrenia, because unfortunately there is no cure for schizophrenia, but we can help manage and abate some of the psychotic symptoms. So when we look at a psychotic disorder, people may use this term flippantly. We're looking at, what does this mean? Well, a psychotic disorder usually has some components of delusions, hallucinations, disorganized speech, abnormal motor behavior, negative symptoms, that means an absence of normal functioning, blunted affect, and reduced speech. And I'm going to give you a whole list of criteria to read. But in short, delusions are going to be, they're false beliefs, okay? Whereas hallucinations are sensory perceptions that don't have an external source. So this is where we get this idea that people with schizophrenia see things that aren't there, hear things that aren't there. So perceiving stimuli where there's no external source. Disorganized speech and behavior. I've included in this slide a couple of pictures and stories of people who struggled with schizophrenia and how these symptoms manifest themselves. But when we talk about delusions, there's different types of beliefs. So persecutory, I can never say that word, grandiosity, referential, and others. So when we talk about persecution, when someone's being persecuted, it means they're being targeted or watched. Delusions of grandiosity. So let me go to the example. With delusions of persecution, there was a woman years ago. Her name was Miriam Carey. She drove from D.C. to Connecticut with her baby daughter to the White House because she believed that President Obama was watching her and stalking her. She did struggle with schizophrenia and this persecutory belief, and it's unfortunate that, it's led to her death because she turned around at a checkpoint, and, that's why we have a lot of conversations about, how do we deal with mental health crises, right? But this is just one of the ways it can kind of manifest itself. Grandiosity would be like thinking, I guess the best comparison is like if someone believed they were Jesus coming again to earth. I guess that's the best example. It's like grandiose, like you are the one, the savior. So these grand beliefs with no really substantial evidence otherwise. I've included here a link to someone who was writing out their thought processes of schizophrenia, and if you read it, it's very disjointed. CIA loves, wants Al-Qaeda, one family. They can't tell you about the CIA. Conversation is in your head. You see and hear what's in your head. I put rooms and rooms and people in people. Everything has a twin. Nothing is seen. Everything has been seen. It's kind of hard to decipher what they're saying or what kind of trajectory they're going, but you can see that the schizophrenia symptom manifesting itself in that disjointed, disorganized speech. So to be diagnosed with schizophrenia for 1 month, the individual must display 2 or more of the following symptoms much of the time: delusions, hallucinations, disorganized speech, very abnormal motor activity, including catatonia. This is like abrupt, stiff movements or holding positions for one really long period of time. And negative symptoms. I have a whole slide on negative symptoms, so we'll tuck that one in our back pocket. At least one of the individual's symptoms must be delusions, hallucinations, or disorganized speech. The individual functions much more poorly in various life spheres than was the case prior to the symptoms. So we have to see kind of a degeneration in how they're functioning with others. Because if someone's having hallucinations and delusions, it may be hard for them to perceive, to differentiate between what's real life and what is something based on non-external stimuli. So that may affect how they interact with others, how they socialize, how they do their jobs. So we see how it kind of affects those different spheres of their life. Beyond this 1 month of intense symptomatology, the individual continues to display some degree of impaired functioning for at least 5 additional months. So that period of time is important. So with the clinical picture of schizophrenia, we have positive, negative, and psychomotor symptoms. So the symptoms, triggers, and courses of schizophrenia vary greatly. This is something that I feel like we're consistently learning more and more about. Some clinicians have argued that schizophrenia is actually a group of distinct disorders that share common features as opposed to its own kind of disorder. And so we're going to talk about those different defining features and how we can relate them. Positive symptoms. So when I talked about positive and negative symptoms, bizarre additions to a person's behavior. Think of positive and negative like mathematical terms. Delusions, single or many. We talked about these. Delusion of persecution, delusions of reference, delusions of grandeur, and delusions of control. So these are listed in full detail in our text. And again, these are false beliefs. Now, someone may have a delusion, right? But it's not enough to diagnose them with schizophrenia just for having the delusional beliefs. Remember, they have to have a whole slew of other symptoms. But having those types of delusions is a psychotic symptom. So maybe even if they don't fit schizophrenia, they may fit the criteria for another disorder. Disorganized thinking and speech, as exhibited in that example, it's kind of disjointed. We can't find there's no clear takeaway from the speech. It's really hard to parse and figure out. Inappropriate affect. This is the saying, like, I'm the type of person who will laugh at a funeral. It's inappropriate for the scenario. So if they consistently display emotions that are inappropriate for the scenario, that may be indicative of schizophrenia. Heightened perceptions and hallucinations. We talked a bit about that. Now, when we talk about negative symptoms, we're looking at pathological deficits. So poverty of speech, so like a reduction or something's missing in their speech. Allogia, reduction of quantity of speech or speech content, may also say quite a bit but convey little meaning. So it's kind of like that letter we read with the CIA. They're saying a whole lot of things, but we're not really understanding the meaning behind it or what's coming out of it. Sometimes they may even repeat things. But there are differences in severity of the scale, because you may have some people have very high functioning schizophrenia where others may have really debilitating types. So remember that as we're moving through the symptoms. Restricted affect. So affect just means emotions. So showing less emotions than most people, avoiding eye contact, immobile, expressionless face. This is all related to, how they feel those emotions and how they convey them. So blunted means like when something's inhibited, whereas flat is just like nothing. Flat, you can't even tell the emotions on their face, but blunted may be like muted. And loss of volition, so loss of motivation. With psychomotor symptoms, we're looking at the body, so awkward movements, repetitive grimaces, odd gestures. Symptoms may take extreme forms, collectively called catatonia. We discussed this briefly, but includes stupor, rigidity, posturing, and excitement. So there's a whole, so you see where some psychologists may say, maybe it's a cluster of symptoms because we have so many differences in how people present their schizophrenic symptoms. These psychomotor symptoms are experienced by about 10% of people with schizophrenia, so it's not as common as others, and it's not a necessary component to be diagnosed with the disorder. There are 3 phases that move through schizophrenia: the prodromal phase, active phase, and the residual phase. So it's kind of like you're not consistently feeling the depth of like the worst symptoms all the time. It may kind of come and go, like start out mild, symptoms present themselves, then maybe come back to mild again. It's not exactly cyclical, but it may ebb and flow, kind of like when you have an anxiety attack. You're not always forever in a high anxiety state. There may be some times where you have certain triggers that are going to make you more anxious than others. So it's kind of ebb and flow. But when we help people kind of abate those symptoms and work through their schizophrenia, usually we see better results with good premorbid functioning, those whose disorder was triggered by stress, because there are some genetic components linked to schizophrenia. Usually the closer the relative, the bigger the chance that someone may develop it, but someone whose schizophrenia was triggered by stress may have better results than someone where there's maybe a genetic component. If someone has an abrupt onset, later onset, usually onset starts between 19 and 30 years old. So with earlier onset, we may see not as good of a progression as late onset. And those who receive early treatment, with most things early treatment is preferred. But to diagnose different types of schizophrenia, there may be different types. Type 1, so it's dominated by positive symptoms. So going back to that chart, those bizarre additions. Whereas type 2, we see those deficits dominated by negative symptoms. Okay, so make sure you understand that distinction. I also put the schizophrenia spectrum disorders in this little chart as it's presented in our text because I think it's a good way to encapsulate those differences without, seeing it side by side. So make sure you understand this chart: schizophrenia, brief psychotic disorder, schizophreniform disorder, schizoaffective disorder, delusional disorder, psychotic disorder, and substance medication-induced psychotic disorder. That's going to be different because that is based on someone's use of a substance, whereas these other effects, they don't have any kind of link to an injury or a substance. So make sure you understand those differences. Delusional disorder is just persistent delusions that are not bizarre and not due to schizophrenia. So you may still have those persecutory, jealous, grandiose, and somatic delusions. Somatic refers to the body. But they're not like, I believe I'm the next coming of Jesus, grandiose delusions. They're a bit more mild, but they're persistent. So I'm trying to think of an example that's not... Like, okay, we've seen some people who... I don't want to use this example, but some people who believe they know everything about this last election, right? Who wholeheartedly will stand by their results, believe everything was fake, and da-da-da-da-da. Not saying all those people have a delusional disorder, but this could be a good example for something that's persistent. They're still holding on to that belief, and they are still going to believe it years down the road. It's very persistent. It's very enduring. So that may be something with a delusion, someone with a delusional disorder may exhibit. No one gets mad at me for that. I'm just saying. We also have schizoaffective disorder, marked by symptoms of both schizophrenia and major depressive episode or manic episode. Whereas schizophreniform is various psychotic symptoms, such as delusions, hallucinations, disorganized speech, restricted or inappropriate affect or catatonia. The reason they have these differentiations is because they do not meet the criteria of schizophrenia. And sometimes that can be related to the duration of the disorder to be actually diagnosed with it. Whereas brief psychotic disorder is brief. It doesn't last the same amount of time or duration as schizophrenia. So make sure you understand those differences as you're moving through the text. For the cognitive neuroscience of schizophrenia, we have been able to locate certain parts of the brain that have its role. You know, certainly the sensory cortices, gray matter, your hippocampus, ventral striatum, and anterior prefrontal cortex. Genetics, possible environmental factors, as you'll see on the next slide. The more cognitive problems someone has, generally the worse functioning in everyday life they will exhibit. So this can be a great source of disability for some people because, as I said previously, when they're interacting with others socially, it's greatly inhibiting. How do we differentiate what's real from what's maybe not, for lack of better words? How do they carry out functions as a student if they write in a disjointed manner? So we think of those implications and how they kind of snowball into other facets of their life. Socially, how do you recognize others' emotional expressions if you have inappropriate affect yourself? Problems inferring intentions from others. So most of us can assume on some level we know what other people are looking for when they're having a discussion with us. Well, typically, people with schizophrenia may have issue with this. So there's worse community function, and we're not able to be with groups of people or to participate as an active member in our community. Oh, I talked about this, but we found one thing I want to make an important note about is that problems during pregnancy and birth, these have been linked to a possible risk factor of schizophrenia. Remember, correlation does not equal causation, but we have seen correlations between problems during birth, older fathers, cannabis use, urban settings. So urban settings are poverty or lower socioeconomic status. We find that people of lower SES have significantly higher incidence of schizophrenia, and it's still kind of in the exploration phase where we're questioning why this group. And typically ethnic groups are people of color. So I think our text says minority ethnic groups, but the more appropriate term is people of color. So what we can do to kind of help treat schizophrenia, besides, giving them therapy to improve cognitive functioning and how they interact with others, which I've included a great link that discusses this Cleveland organization and what they do. Kind of what is CET? So I'm going to pull that up. Let's see if it'll open. It's called CET Cleveland. So I found this clinic online, and I'm hoping the link still works. There you go, cognitive enhancement therapy. So it talks a bit about cognitive enhancement therapy and how we can increase people with schizophrenia's social capacity and work capacity, vocational capacity. But we can't necessarily cure it, but we can help abate some of the symptoms through therapy and drugs. So some types of antipsychotic medications may help to relieve some of the hallucinations that people are having. It's just a matter of, what's going to work for this person in this scenario in this point in time. Yeah, so that's it. I tried to keep this under 20 minutes. That was a little long. Maybe I'll cut it. But if you have any questions, check out that CET Cognitive Enhancement Therapy page. Good resources on there for you. And email me if you have any other questions. And I hope you all have a great week.